Thank you very much for visiting. And the presentation is a really challenge for me because the constrictive pericarditis, it's usually referred to the cardiac surgeon, but our center will try to change the situation, and now it's a not big challenge, but a great challenge for thoracic surgeon to do something. Because of the knowledge of thoracic surgeon is allowed to work with very severe adhesion in the pleural cavity, more when the cardiac surgeon which work with just a cold heart, it's unmoved heart, unbeaten heart. It's very simple surgery sometimes, if you know anatomy. And nobody likes to do, the cardiac surgeon to do this surgery take a time because it's lasted more than 3 hours. And the number, usually we refer to the best friend or to the other centers for somebody to do so complicated surgery. And experience from the different centers are also different from for instance, from the Japan and from the Canada. It's from the Japan, more than 300 cases for 4 years, and from Canada, it's only 90 cases for 20 years. So it depends on the center, depends on the relationship between the cardiac surgeon and the cardiologist. It's collect the patient in our hospital. So the incidence is rather low, and mostly it's idiopathic now, but in 60s was over 60% of related to TB disease. The constriction of the pericardium. Also, the number of patients after surgery is increased. After transplant, even after heart transplants is increased. And more than maybe up to 30% it's referred for the surgery can be referred. And we observe the epidemiological shift, if I can say like that, because the Western country is more related to the different fibrotic tissue disease, but the Asia and Russia and the other countries, the Middle East, related to still infectious and TB disease, the construction pericarditis. It's a really simple presentation in the initial phase. Usually with the therapist and outpatient somewhere in the office can obtain a very simple suspicion of this diagnosis. But unfortunately, we frequently miss these very simple symptoms and treat the patient from different diseases, not from the beginning of constriction. So it's very simple. If you refer the patient for chest X-ray or chest X-ray, you just find the calcification. But it's interesting, calcification does not mean deconstruction. MRI, CT and MRI, of course, it's 4 millimeter of thickness. It's presumably it's construction, but with sensitivity more than 90%. But sensitivity related to the thickness, not for the construction, not for the hemodynamics changes. Of course, we can do a 3D reconstruction. It's very useful for the surgery to plan the access and the plan what kind of the volume of the surgery you can perform. It's a nice picture, really clear. But of course, the most sophisticated is echo is a gold standard to explore the patient with supposed constriction of the pericardium, up to 90% of sensitivity. There is a number of tests. I cannot repeat because sometimes even thoracic or cardiac surgeon cannot understand what's happening in the heart, but cardiologists, experienced cardiologists can describe it, and we find the really still epic movement. We can find even hemodynamics changes, including jugular vein changes in the pulse, and also square root changes. It's distinguished between the pulmonary artery and pulmonary atrium pressure during the inspiration. So I want to stress, emphasize, it's a 3 elephants base for constrictive pericarditis diagnosis. It's echo, CT, MRI, and hemodynamics. But it was a surprise when I prepared the presentation. Even there's not enough to do some time to do can we judge about the restriction because it's maybe even about the constriction, because sometimes it's a restriction, so we have to choose which kind of surgery should be did, or transplant or pericardiectomy. So the final steps, it's endomyocardial biopsy. We should exclude amyloid, any inflammation, or WATS or small thoracotomy, but it's beyond the limits. When surgery should be performed? As soon as possible when the patient comes into the clinica. Usually we come with the blow-up, the symptoms with the different type of comorbidities. For instance, this picture of the belly, the patients undergo orthotopic transplantation 1 year ago in our clinica, and he came with a really severe heart insufficiency. It treated not in the hospital from the heart insufficiency at least 6 months. Nobody suppose it's a constrictive pericarditis. So even the patient with decompensated, so it's still possible to do a surgery, even in a salvage intention. It's very simple steps. If you find the constrictive pericarditis, you should refer for the surgery. Not to do a long way to treat this patient. It's useless. The approaches is a gold standard sternotomy. By the way, we can use clamshell or bilateral, even the WATS, but it depends of what aim you follow. But usually the sternotomy, I repeat, it's a gold standard. You can access for all surface of the heart you need it. Anesthesia, it's the most important things. You with anesthesiologist became a big friends, and the anesthesiologist should keep the blood bank on his chair, and behind him a cardiopulmonary bypass. Because the surgery, it's on the one side it's very simple, for the other side it's very difficult to treat, to fix the complication is occurred. The complication should be different and coronary artery damage or moreover defect on the heart. So the blood loss should be very rapid and quick, and the heart maybe stops. So you should be prepared for massive transfusion and even for circulatory arrest. Also, you have to prophylax the stroke and liver and kidney failure. Nothing more nor less. For the surgery, its boundary of the section is really simple. It's from left to right. You should release the left and right ventricles. So if remove the pericard from phrenicus to phrenicus, and also you unsling the orifice of lower and the upper vena cava, upper part, and unsling upper hemiarch of the pulmonary arteries and veins. In schematical scheme is shown what should be done. It's a mistake if you try to remove the posterior part of the pericardium. Is it partial pericardiectomy justified? Sometimes yes, but you have to do to remove as much pericardium as it possible, because the results is different, and the long-term result for subtotal pericardiectomy is much better than for partial total pericardiectomy. And the sect started from the visible healthy border of the heart, aorta root level, and you use the scalpel with a longitudinal incision from the basis to the apex. We try to find the lower, but sometimes it's difficult to find. If fibrotic adhesion, you use the scissors or monopolar coagulator. If calcified, just a cut, and never push or pull the tissue. the results, it should be the effect on the myocardium. It's a most mistake if you try to do a blind dissection. It's very important. Sometimes if the pericardium is calcified, the teeth from the inner part of the pericardium is ingrown to the myocardial tissue. Sometimes it's not possible to remove these teeth. So you just cut the teeth and leave it on the place and try to bypass the problem in that case. And there is not problem to leave it. The problem, if you find a defect, don't be shy to use monopolar electrocardiography, not bipolar, because the bipolar is useless in this case. You just spend the time and like a monkey business to do the cautery, the small bleeding. And the right ventricle and left ventricle should be released. Bands between the right ventricle and pulmonary should be exceeded, and the right atrium, if the right atrium cannot be released, you can leave it, because hemodynamic it's not important. And finally, all wounds, you see the well constructed, filled by open heart, and it's constructed very well. It's like a battlefield. And rapidly, even after surgery, after 1 hour or immediately, you have a little changes. So the pressure in pulmonary artery is decreased. Central venous pressure is decreased. The condition of the patient is became better. And 7 days after pericardectomy, you see the differences in the heart changes. Also, you see the hemodynamic changes. It's better. And follow-up mortality depends of what kind of etiology you have. For idiopathic, it's a much better survival rate. And for renal, or if they have constructive pericarditis after irradiation, it's maybe worse as results. Also, renal insufficiency, poor ventricular function, pulmonary hypertension on time of surgery, chronic heart insufficiency, hyponatremia, ascites, hyperbilirubinemia, maybe not advantage from the surgery, but we still do this. We have a lot of experience, but it's only 19 pericardioectomies, with only 1 with cardiopulmonary bypass, 2 pericardioectomy after heart transplantation, after previous heart surgeries. The rest of the was 40%. 40% of the rest was due to TB disease, and with aortic valve prosthesis, and 1 patient died. Half of them was done by thoracic surgeon. So finally, I'm going to say that the surgery is a teamwork, and I emphasize, if you do a surgery earlier, you have more good results after. Thank you very much for your attention.